Ah, how about this?
Great. But now you are little looking little dimmer. I mean, the lights in the room are little dim, is it?
No, it's a different camera. So
Oh, okay, okay. Doesn't matter. Doesn't matter.
yeah, I think we might suffer with this tonight. What do you say?
Oh, that's absolutely fine. Ah, now it's great. Now you are looking fabulous. Absolutely great,
All
great.
right.
Okay. So before we start, I think let me have the pleasure of introducing you to our brilliant residents and faculties of the Department of Surgery of All India Institute of Medical Sciences in Bhubaneswar. That's in the eastern part of the country, where I had already extended a lot of invitations to you also previously. So it will be a pleasure to have you sometime there also, here as well. Okay. So I think our residents are all eagerly waiting to hear a man who has really come up the ladder with all his own effort. And he himself is it's not only a guest lecture. My other motive is to just to enthuse the young minds with a personality who can really impress them with what he has achieved in his life, and absolutely by sheer labor and sheer effort. So I really appreciate Brother Professor Rutledge is a man to be emulated. Is a fantastic human being, a fantastic fellow. I mean, who is down to earth like anything, and we have been in relationship for quite some time. So we know each other for quite some time. So just to introduce Professor Rutledge to the audience. In fact, Professor Rutledge had his undergraduate career in University of Florida. Then he did his residency in University of North Carolina. Then he was associate, assistant, and full professor of surgery of the Department of Surgery in Trauma, Critical Care, and Bariatric, associate chief of staff, and first chair in the section in the medical informatics. He was the director of the same North Carolina Trauma Registry. And in 1998, Dr. Rutledge decided that enough of teaching and getting confined only to North Carolina. Let me go worldwide. Let me be a teacher to worldwide audience. Then he quit his job and he is into private practice from 1998 till date, and he'll continue till end as well. So I wish Dr. Rutledge, you have a fantastic health in years to come, and you be the source of inspiration to many young minds and many young brains. So he has published, in fact, many literatures. If I go on counting his accolades, maybe it will consume the entire webinar time. So I will just confine to some of his accomplishments. While he was doing his surgical residency, and he was a brilliant student right from the beginning, there's no doubt about that. But the thing that brought him to limelight in the world is the mini gastric bypass. And in fact, in 1997, when Dr. Rutledge was managing a trauma care victim, there he employed the general surgery principle into bariatric surgery, and that's how evolved this mini gastric bypass. And he, in fact, made this mini gastric bypass such a simple procedure to be followed. Now, probably the entire world is just amused with this technique and this surgical skill that can be transferred to a patient who needs a bariatric surgery. And from that day onwards, he has performed more than 6,000 mini gastric bypass. It's a phenomenal figure in any standard. And that's not the only fact. He is an enthused teacher. He is an excellent surgeon who is always interested to teach to the younger brains and younger minds. Of course, I am the only old fellow here, Dr. Rutledge, because any heads are always old fellows. So naturally, I am the only old man here. But rest, all the young are waiting to learn from you that the skill of doing a mini gastric bypass, the nuances that a surgeon can encounter technically, and what are the indications, contraindications, how and where we should go ahead to do a mini gastric bypass. In fact, MGB is a procedure which has taken the entire world into an absolutely different platform in bariatric surgery. And quite often now it is more accepted worldwide as one of the very friendly procedure. So it is a patient-friendly procedure. So how it is the procedure is patient friendly, how the surgeon can make it more patient friendly, how the procedure can be made surgeon friendly as well. Let's now listen to Professor Rutledge. The entire screen and air, everything is yours now. So you can just tell few words before you start your presentation. Dr. Rutledge, is over to you.
Well, you're much too kind. It's my honor to be with you and to talk about the MGB. And I will summarize the enjoyment I have about speaking with this is because while we think the MGB is good, the published literature shows that it can lead to complications and death. And so how can this be? We see many articles and my own experience and Dr. Kular and others in India having superb results. And then we see other problems. And so what we think is there is some basic, simple, general surgical techniques which are violated by some of the new surgeons who adopt the MGB without thought. And so my goal tonight is to tell you that I don't think that this talk alone is adequate, but the MGB can be a simple, safe, powerful, reversible operation. And I'll try to give you some suggestions on this, and I would say that I am open to doing anything I can to help you become good MGB surgeons. And I don't think that I'm a especially good surgeon. I think I'm an old surgeon. I'm an old general surgeon. And my long experience allows me to give you some advice, not because I'm a great man or a great surgeon, but because I have been an old man and I have done a lot of surgery. I've made a lot of mistakes, and I think I can help you and guide you. Please take advantage of me. And so with that, I'll begin my talk if I have your permission, sir.
Sure, definitely. It's a pleasure that it's not only your age that you are old. A surgeon is old not by his age. The surgeon should get old by the amount of surgery that he should be doing. That's probably determines the surgical age of a person. So in that way, you are surely old. And you are much older than me in that also. Doesn't matter. You are welcome.
And we shared a funny saying that we say in surgery. There are old surgeons and there are bold surgeons, but there are no old, bold surgeons. So that is my beginning and the end of my talk tonight.
True, absolutely true. There are old surgeons, bold surgeons, but there are no old and bold surgeons. Absolutely.
All right.
Please.
One moment and I will get started.
Sure. You need to share your screen first.
Can you see the slide?
No, it hasn't come. You have to click the present now button.
Can you see the screen now?
No. Click on the present. Yeah, it's coming now. It's coming. Oh, yes.
Yeah, good. Yes?
Yeah.
So how good is the MGB? And I want to give you a few quick examples. This is from diabetes in India. And as you know, I'm sure, diabetes in your country faces a new pandemic. When the pandemic of COVID-19 goes away, your country faces, along with China and America and other large countries, with a coming epidemic in diabetes. I'm going to refer to some data that Dr. Kular and I are presenting soon on the 10-year outcome of MGB. 10 years after MGB, hemoglobin A1C is less than 7 in 96% of patients. Here's our data. Preoperative hemoglobin A1C was approximately 9 with a maximum of almost 15. And at 10 years later, the mean hemoglobin A1C is 5.8 with only the maximum of 7.6 in 1 or 2 patients. This is almost a cure of diabetes over 10 years with one simple, short operation. Not only that, uniquely compared to the sleeve, the MGB can be titrated to effect. In other words, here on the x-axis, you see the biliopancreatic limb length in centimeters, from a short 1.5 meters to as long as 3 meters or more. And as we increase as we change the dosage of MGB, the delta, the change in hemoglobin A1C, increases. That means a patient who's very sick can get a more powerful operation. Not the sleeve, which is a sleeve, which is a sleeve, but it means in your hands with an MGB, you can choose more power or a more conservative choice. Another example here is to look at the difference from the new GLP-1 drugs. The new GLP-1 drugs. The delta on large-scale studies of a GLP drug, even over time, is less than 1.5 hemoglobin A1C units. Yet, here is the change in hemoglobin A1C units for MGB. At 10 years, we have no 10-year GLP-1 data. But here's the thing, a GLP-1 drug in the United States may cost up to $10,000 a year, and over 10 years, the treatment that received by the MGB is worth maybe more than $100,000 in US healthcare costs. So why are we here, and what is this all about? What we'd like to talk to you about is say that the MGB can be done easily and simply when you learn how to do it well. But if you treat it as, oh, nothing more than a sleeve with an anastomosis, we believe there are tricks and traps that can lead to deaths and complications. Low volume surgeons, those who are not well trained in doing the MGB, have more leaks, more reflux, more revisions. They make it more like the old loop gastric bypass done by Mason, and less like the general surgery, antrectomy and Billroth 2. Failure can come from the primary MGB, sleeve to MGB, and what we see is failure and complications occur in the hands of less experienced surgeons. So we'll talk about that tonight. Now, when surgeons speak to you, they always brag about their results. And so I'm going to brag here and say no one else on earth has comparable results. And I encourage you to talk directly to my patients who are 5, 10, 15, even 20 years after their MGB, done by me, Rutledge. And you can talk to them by the hundreds tonight, tomorrow, and any day on Facebook. Facebook is, of course, a silly social network for foolishness and cat videos. But in addition, there are more than 5, 6, 7,000 MGB patients of mine and other surgeons that you can talk to. And when I claim excellent results, I have 20-year results. No one else on earth has 20-year MGB results. I do, and you can talk directly to those patients tonight or any day. The MGB is a superb operation when done right, and I can show that in 5, 10, 15, and 20-year outcomes. Talk to thousands of my patients on Facebook at Dr. Rutledge anytime, and compare that to sleeve. So I'll briefly read just a few. 20 years after MGB, hello, Dr. Rutledge. I can't believe it's been 20 years. I was 300 pounds. I lost 150. 20 years after MGB by me. 18 years after MGB, I was 276. You saved my life. I went to a size 2 over the last 20 years and gained up to a size 8. 20 years post-op, 11/1/2000. I weighed 252. I currently weigh 135 and I'm 71. You can talk to my patients tonight that are 20 years after their MGB. I'm 60. I weighed 328, 2003. I'm now 124. You can talk to my patients tonight. Thanks, Doc. I got an MGB 11 years ago. On the other hand, go to Facebook and watch and read about bariatric surgery tragedies. There is a Facebook group, Weight Loss Surgery Ruined My Life, Sleeves Ruin Wise, Lap Bands. Compare when you talk directly to patients. How good is the MGB? How about my own data? In 3,000 patients living with MGB 5 to 20 years out, we asked them to classify their MGB: poor, I lost too little weight; fair, good, perfect, or I lost too much. And this is the data. 40%, 49%, 40% perfect. I lost all the weight I had hoped for. 50%, 49.9% good. I lost a lot of weight, I could lose a little bit more. And only 1.9% poor, I did not lose enough weight. Compare that to sleep. Compare that to Roux-en-Y. And compare that in thousands of patients over up to 20 years. Here's that same data. Good, almost 50%. Perfect in 40%. Perfect, patient's judgment. Perfect in 40%. Failed MGB, really? The number one reason for failure of the MGB, I will show you some tonight, is technical performance issues, doing it badly. Number two is patient's diet history, and I won't go into that too much because already your chief has told me that he wants to know how to do it. But don't forget, there's more to it than that. I will also tell you that in the past week or two, I've had two surgeons from around the world, one from Jordan and another from Australia, who killed an MGB patient. They had 2 deaths. That's not necessary. They did not learn. They did not know how. Don't hesitate to call me anytime, night or day. Complications are bowel reflux or weight loss failure or regain. These are technical errors, and we'll talk about some of those tonight. There are these paradoxes in the published literature: excellent weight loss versus excessive weight loss, no bile reflux or rare compared to severe bile reflux, long bypass versus limited bypass, rare versus common marginal ulcer, and malnutrition or malabsorption. Why are these paradoxes in place? We would argue it's because of not learning how to do the operation well. This is my travel and teaching around the world. You'll see the United States, South America, all of Europe. This red dot here is the Azores in the middle of the ocean, the Middle East, Egypt, Israel, Saudi Arabia, both Pakistan and India, Afghanistan, Kazakhstan, around the world. Special thanks to my host at the present time, Dr. Kular and Dr. Magenda. And here is me in Australia, Pakistan, Portugal, Turkey, UK, Spain, Kazakhstan, Italy, and all around the world. I am committed to help you be better surgeons. Please feel free to contact me and ask me if I can help at any time. What makes an ideal surgery? It should be low risk, have major weight loss, be easily performed, have short operating times, have an outpatient or short hospital stay, minimal blood loss, and a good exit strategy. The sleeve can never be undone. The MGB can be undone in less time than it takes to have a haircut. And if you look at these 30 measures of ideal weight loss surgery, the MGB meets all of them well. The MGB is simple, elegant, effective, durable now for more than 15 years, up to 20 years. It's powerful, it can be tailored to the patient, and it's easily reversible and revisable. It's standard general surgery. This is not a sleeve. This is a callus gastroplasty. It's non-obstructive. It's not designed to be tight or obstructive. We can talk about that if you wish. And this is a simple anticolic Billroth 2 gastrojejunostomy. It's not a Roux-en-Y type gastric bypass. It's not supposed to be tight, narrow, or twisted. And we see these mistakes all the time by new MGB surgeons. Let me give you a little history. The first MGB was done as a trauma surgeon 23 years ago now. A 1997 patient was shot in the belly dealing drugs. He was shot 6 times with a .357 Magnum, 9 o'clock on a Thursday night in September 1997. And I did a gastrectomy a distal pancreatectomy, and a splenectomy, and I repaired numerous small bowel perforations. And I treated that patient in the middle of the night by that antrectomy, distal pancreatectomy, and splenectomy. I reconstructed the stomach with standard general surgical technique. So the MGB is not unusual. The MGB is not different. The MGB is a Billroth 2 gastrojejunostomy with a callus gastroplasty, and that's all. But still it's misunderstood. Still it's not understood well. People make errors so that they make more of an operation like the old 1967 gastric bypass with a loop done by Dr. Mason. That was wrong. It failed. It was not adopted because this is not an MGB. Now let's do the MGB. It's an easy 15 to 30-minute case. The patients can often go home the same day, but it needs to understand how to do it. These are the ports, and we can talk about them later. We dissect the lesser curvature at the junction between the body and the antrum, the crow's foot. Then the staple gun needs to be perpendicular, and we see common errors where patients, surgeons sit in between the legs and staple up this way, creating a bird's beak and making a short pouch. That's not the way to do it. Perpendicular to the lesser curvature, creating a defect like this. Then we want a wide tip, and we'll show you why, and then we staple up towards the EG junction, but we stay lateral to the EG junction. This is not a sleeve. When I go to talk around the world about the MGB, there are other sleeve surgeons talking there, and they politely will ask me after they've had many sleeve surgeon presentations, they'll say, Dr. Rutledge, what about stents? What about stents for leaks? And I'll say, sir, we don't know stents. We don't have leaks in MGB. We don't have EG junction leaks because we don't dissect in that area. You see here, you see here. This is not a sleeve. This is where we want the gastrojejunostomy and avoid the EG junction, important points. An anterior gastrotomy is made, jejunotomy is made, then we staple. And how this is placed is very important. We'll look at this if there are some questions. That's the gastrojejunostomy, and that is sewn or stapled. And that's it. So that's a good opening presentation. I'll show you a quick video now, and we can have some questions. But now we're going to show you that same operation in video format. So I'm going to stop sharing. And now I'm going to turn to the video. Can you see the video?
It hasn't come. No, you need to share the screen again. Then you have to play the video.
According to the video is playing, and I'm sharing it. I will stop.
It's coming.
Share again.
Yeah. Now.
Yeah, I thought so. Good.
Yeah, that's fine.
Okay, so now we will stop and go back and look at the port sites. So you can see the port sites?
Yeah, absolutely.
This is mid-epigastric port, the right lateral mid-gastric line, 2 hand breadths below the sternal notch, 5 millimeter port here, and mid-clavicular line here. These are the ports. And now we'll go and start the operation again. This is the lesser curvature. We dissect here and see the staple gun in come perpendicular. Almost the greater curvature. You want the big tip, and we'll see why later. There is the staple line. But see, almost greater curvature. You see the staple gun is coming this direction, and many surgeons, I'll show you if you have questions later, that could come the staple gun like this and create what we call a bird's beak and a twisted pouch. You see across, many sleeve surgeons, they're already trying to go to the EG junction. This is almost perpendicular, you see? That creates this wide base for a wide open gastrojejunostomy because the mechanism of action of the MG is different. And look here, you see the wide base? This is the way it should be. And here we don't dissect the EG junction, we just dissect here in the posterior wall. Under direct vision, right on the gastric wall. And then we divide the stomach, staying very lateral to the EG junction. No leaks from the EG junction. And there it is, beautiful. You see the broad base, okay? And we run the bowel. And this is very important. It's a little advanced for you to understand it right this moment, but if you want, we'll go into more detail. But that's perfect. So now there's the gastrojejunostomy, put the bougie across, and then we're going to evert and have an everted stapled closure. And there are a lot of reasons for that. I can explain it to you later. This is a good way to do it. A lot of surgeons like to sew it. That's okay. They don't really know why they want to do that, but it's okay. So that's stapled. That's done. This operation took about 36 minutes. And my shortest operation that I did was about 17 years ago. It took 16 minutes. And so a good MGB can be very smoothly and simply. We don't encourage you to try and do it fast, but the MGB demands, if you do it well, very little time. So I have more to show, but I thought I would stop there and give a chance for questions. And Dr. Manash, if you have comments, I can show more, have more slides, more details, but that's a good introduction.
Absolutely. That was fabulous and fantastic, Dr. Rutledge. And more than the presentation, our young residents have really been enthused by your experience and that the journey that you have taken, how an inventor is right now talking to us, the technique which he invented just while managing a simple trauma surgery, and that came out to a procedure which is now well accepted worldwide. People are now opting that this should be the go of the world for bariatric surgery. So I think that's a good enough enthusiasm that you have inculcated into this talk. That was really fabulous, apart from the tips and tricks. So in fact, the tricks and the traps, in fact, the traps are more important. Unless the procedure is done well, that might lead the surgeons to many traps as well. So you have given many key points that to be absolutely taken care of, like firing the stapler absolutely vertical at the crow's foot. That need to be taken care of. And having a broad base. Broad base is probably most important because the drainage will be absolutely very convenient, comfortable, so that the short pouch will be having absolutely no problem. And going lateral to the EG junction, that is much more important. So no dilly-dallying at that area as it's done in a sleeve. So these are few points that you have highlighted so well, and that must have gone into everybody's mind. Now let us open the floor. Our faculties and residents all are here. So this is a small department with 9 faculties, 12 academic junior residents, around 13 senior residents. There is a postdoctoral fellowship course in minimal access surgery. Now, right now, we do not have candidates, but one batch they have passed. So, and all these people are really enthusiastic surgeons who are very much enthusiastic for minimal access surgery. So, I think you'll be facing many questions coming up from the floor. So, let's have some discussion, some questions, some queries. If anybody of you, please join in.
While we're waiting for questions, I'll mention a few more topics.
Absolutely, absolutely.
If you think about it, I said some things that are radically different than the standard Roux-en-Y and sleeve.
Absolutely.
So if you think of the Roux-en-Y pouch the way I was taught to create it, it's a small pouch, it's a tight pouch, and the gastrojejunostomy sometimes only a few millimeters.
Okay.
Yet I tried to emphasize the opposite for MGB. The same thing is that the sleeve and the Roux-en-Y are not dependent on bypass, but they're dependent on mechanical restriction. In fact, I would say it better is maybe obstruction. And my point is here to kind of point out that the mechanism of lap band, the mechanism of the old vertical banded gastroplasty is very simplistic if you think about it. They say there is a big road. I am not far from National Highway 1 here in India. And if we went out tomorrow morning and put a roadblock there, fewer cars would be able to pass.
True.
And that's the idea of a lap band, of a vertical banded gastroplasty. And I think of the sleeve. There is a partial roadblock, a mechanical obstruction.
True. So I think
MGB, Sorry?
No, I think that mechanical obstruction that we encounter in a standard sleeve gastrectomy or in a Roux-en-Y gastric bypass, where you have a small pouch, and that is absolutely taken care of in an MGB, where you do not have any obstruction ahead, everything is open. So naturally, the chances of all those complications that are expected in those two procedures are absolutely taken care of here. And that's what you mean to convey the message to all of us?
No, I would say it just slightly differently, sir. And forgive me for interrupting. But I think that raises the question when a good sleeve surgeon or a good Roux-en-Y surgeon adopts the MGB, they have that mindset that there is a need for a mechanical obstruction. So they'll often create a tight gastrojejunostomy. I have some videos of gastrojejunostomies done by good, honorable surgeons, but they make a very tight gastrojejunostomy because they are thinking that the MGB is based upon mechanical obstruction. And so I'd like to talk for a moment about that and maybe describe the mechanism of action of MGB to you, if I have your permission.
Yeah, please.
So the MGB has no obstruction. What we think the ideal MGB is that when you swallow a large bolus of food, there should be no obstruction in the esophagus. In other words, the bolus of food should go easily through the esophagus, yes?
Okay.
And the new gastric pouch of the MGB, similarly, should easily pass through the MGB pouch. It should not have any mechanical obstruction. And the gastrojejunostomy, similarly, no obstruction. So then the question arises, how does the MGB work? What is the mechanism of action of MGB? And the mechanism of action is found in the literature from the World War II time period. The mechanism of action of MGB is what's called, and what you know, sir, post-gastrectomy syndrome. The mechanism which the MGB interferes with the eating of excessive calories and food and fat and sugary foods is related to dumping the food immediately through the esophagus, through the gastric pouch into the small intestine. And when that food dumps, and of course, you know I'm using the word dump intentionally, when that food is dumped directly into the small bowel, they will find that Coca-Cola and candy and sugar and ice cream causes a very severe restriction, but not a restriction of obstruction, not a mechanical obstruction, but a restriction of dumping syndrome, type 2 dumping. The second type of dumping, as you know, is type 1 dumping, and that's where, of course, to the residents, there is an osmotic action of the food within the small intestine, so it causes fluid to be drawn into the small bowel and have dilation with a pain of stretching the small bowel equal to small bowel obstruction. And so again, there is restriction, but not mechanical obstruction. And so when a new sleeve surgeon adopts MGB, they're confused about this topic. They're saying we must make a tight, narrow pouch. We must make a tight, narrow gastrojejunostomy and numerous other areas. But the mechanism of action of MGB is a post-gastrectomy syndrome dumping. And the research is interesting in that vagotomy, pyloroplasty, Billroth 1 and Billroth 2, each one has progressively more severe dumping syndrome. Not only that, as you lengthen the bypass, the dumping syndrome gets worse. And that gives us the power to titrate the power of the operation to the needs of the patient, which is unique amongst bariatric surgery at this time.
So what's the length of bowel you prefer? It's 150 centimeter, is it?
That's a complex and not a short answer. There are a variety of factors that make a difference, and I would not want to give your team the idea that it's a trivial decision. What we think is it's a very powerful operation. If you bypass too much, the patient can have complications. If you bypass too little, then what we see is that it's less effective. It's almost never less effective than a sleeve. But understanding the details of selecting the BP limb length is something that requires a lecture or two to go through the details. I'll just mention one thing. You know, of course, the Hindi and other populations often are vegetarians. And conversely, in the United States, every American is surrounded by food 24 hours a day. If you just move anywhere in the United States, your hand will touch food. So what we have found is Kular and I both have noticed that as the BP limb is longer, there is a greater impact on weight loss and diabetes and other measures of outcome. But that Indian patients are more sensitive to BP limb length than American patients. And we think the relationship is related to the fact that in America, Americans are drenched in food, junk food, chips, colas, things like that. So my opinion is that an MGB patient in the US, I would bypass a little more. And particularly in certain patients, let's say elderly, young, liver disease, things like that, I would choose to be more conservative of bypassing. And vegetarian and strict vegetarian and types of vegetarians, all these things go into the decision-making of the BP limb. And it's a complex topic, which I'd love to talk about another time, but it's something that I believe takes as much skill as deciding where to put the staple gun.
Okay. So I mean that then the bypass, the BP limb length all depends upon the food habit and things and scenarios that the patient is expected to undergo in the post-op period that you mean to say. So if is a weird, I mean this junkie is probably you need to go a little higher limb length and in an average.
Yes, absolutely. In other words, if you think of a sleeve, if you have a super obese, a morbidly obese, or a borderline obese patient, a sleeve is a sleeve is a sleeve. Okay. In MGB, what we recommend is super obese patients. I think if you think about it, obviously we recommend bypassing more, but we don't take that lightly. That is serious business. It's as if you decide to use a more powerful antibiotic, a more powerful blood pressure pill, and more powerful drug of any type. It's life and death when you choose to use a more powerful technique. And so what we find is often young surgeons don't think twice, and they see a super obese patient and they have little experience and they make a long bypass without understanding how to make that decision and what are the implications long-term for being cautious about the patient's long-term results.
Okay. So that means it has to be very judiciously decided that should a patient the bypassing the length. I mean, before deciding the length of the BP limb. So on an average, for an Indian patient, should it be somewhere between 130 to 150 centimeter. Is it ideal? Is that the?
Yeah, we think at the first 100 cases, we think you should be very conservative, and that 130 to 150 is conservative in India. If you have a sicker, older patient, you want to err more towards the 130. And if you have a patient with good follow-up, good dietary habits, not alcohol, not a heavy smoker, things like this, then my bias is that's a good choice to choose to be a little bit more aggressive. But we think for the first 100 patients, be very conservative until you learn, because each of us have a variety of other factors. So when you count 150 centimeters, it might not be the same as the way Kular or I count. Okay. And so until you learn that, we think you should be cautious. The second thing is anesthesia makes a difference. So you remember parasympathetic and sympathetic tone affects bowel length. So a patient who's in pain or cold has a release of sympathetic tone, which will shorten the bowel. If that is occurring, you have a rough anesthesiologist, for example. What we have seen is you might think you're bypassing 150 and you might be bypassing significantly more. So until you and your team become skilled, we recommend being conservative.
Okay. So that means it is better to err on the lesser length of the bowel than erring on the longer length of the bowel.
It's power should be cautiously used. When you have great power, it requires great responsibility.
Absolutely, absolutely. And what do you use a bougie while making the pouch? When you go after the first fire, the second fire, third fire, do you prefer a bougie at that time?
Yes, and using the bougie is a good idea. We feel that we often see it misused. And so I'll give you an example. I think many of my friends who are sleeve surgeons, they want to hug the bougie with the staple gun because they want that narrow pouch because they're looking for the mechanical restriction. And they've seen patients who failed the sleeve because of dilation or a large pouch. And so what we say is don't hug that, because when you're close and as you close the staple gun, you may actually pinch or even tear the stomach wall and lead to a leak along that staple line. So be generous, be relaxed, because this is nothing more than an extension of the esophagus. We don't want it to be a reservoir. It shouldn't be a reservoir of the stomach. But on the other hand, whether your esophagus is 2 centimeters in diameter or 3 centimeters in diameter, in my personal opinion, I don't think that affects the weight.
Okay. So, I mean, that's very important that you have passed on the message so clearly that we need to be extremely generous and relaxed while doing this pouch. No need to put in a bougie, no need to go hug the bougie, no need to make a restrictive pouch. I mean, so that you need to stay relaxed and generous. That's probably the catchwords that you have given us. That's good. That's good.
I would use a bougie, but I would be a little distant from it, maybe a centimeter or so.
Okay.
Yeah,
and,
sorry.
Okay. And do you prefer using bougie? Do you use bougie? No, not at all.
Yes.
What size? 36 French, is it?
Yes, I think a large bougie like that is a good choice. I don't think the size is critical. I think it's important because it tends to straighten out the stomach and make the pouch tailoring look more like esophagus. But many people that I talk to who are sleeve surgeons or new MGB surgeons are trying to make a narrow pouch. They have in their mind the mechanical obstruction idea. And so I keep going back to the fact is give that up. MGB is not a mechanical obstruction. It is a dumping syndrome mechanism.
True, true. So in fact, on that principle, this surgery has been developed. I mean, that gastrectomy principle, this has already been developed, and it's giving one of the very good results in comparison to sleeve. Absolutely, that's true. So could we have any other questions from the floor? Any faculties, residents? I mean,
good evening, sir.
Yeah, please. Good evening.
Good evening, sir. I'm Dr. Ankit. I'm working as a senior resident here.
Could you make it visible, Ankit?
Yes, sir. Good evening, sir.
Yeah.
Sir, I have a question for Dr. Rutledge.
You must be able to see him so that, yeah. Please, go ahead.
Yes, sir. Sir, I had a question. So how do you select the patients who will be candidates for undergoing mini gastric bypass? Like we say, we should not perform a Roux-en-Y in case of smokers, or we should not do a sleeve in case of patients with reflux. So how do we select which patients ideally should be undergoing this procedure? And can we do this procedure on patients who are already having GERD? Is this a feasible option for a procedure in those patients?
Well, that's a good question. So let's talk about patient selection. So number one, the fear of smokers and marginal ulcer. So I will give you a radical idea. I want to give you a very radical idea. Why do Roux-en-Y patients get marginal ulcer? You say smokers, but they're not all smokers. Smokers are more common. Why is it that some MGB surgeons have many marginal ulcers and some have few? Why is it that the MGB and Roux-en-Y in some series both have around 3 to 5% marginal ulcers, whereas other series of Roux-en-Y and MGB have very low incidence? MGB, many people say, I fear MGB because of bile reflux. Yes, you've heard this?
Yes,
But if bile reflux is bad and causes irritation and gastritis and marginal ulcer, why is that the MGB with bile in the stomach, why is the marginal ulcer rate low, and as low as and sometimes lower than other reported series of Roux-en-Y? Now, it may be the surgeons are not reporting well, they're not following their patients and other things, but I'll give you a radical suggestion. Imagine that you are taught how to do a good bowel anastomosis. A good bowel anastomosis needs to show healthy vascularized tissue to healthy vascularized tissue. Yes?
yes, sir.
Now, let's imagine that instead, when you do your anastomosis and you sew stomach to bowel, that you make the tissue ischemic. You take the blood supply away. And then on top of that, you put in a number, maybe 100 or more foreign bodies, titanium staples. Can you imagine that that location, ischemic, poor blood supply, and filled with titanium staple foreign bodies would be a likely spot for marginal ulcer? So imagine, here's my theory, here's my idea. When I see many people create their Roux-en-Y or their MGB, I see them devascularize the tip of the gastric pouch. And then they have remember that the gastric pouch has the lesser curvature and then a neo-greater curvature, you know, the staple line, right?
Yes, sir.
Neo-greater curvature has no more gastroepiploic vascular supply. That's been cut away. Now, when you staple, you're going to put a staple gun between the neo-greater curvature and the lesser curvature, right?
Yes, sir.
So where is the blood going to come from on that lateral aspect? Because now the collateral blood supply has been blocked by the gastric staple line. Do you see what I'm saying?
Yes, sir.
So if you make the two staple lines, the lateral staple line of the neo-greater curvature, say it's 1/2 to 1 centimeter away from the staple line on the lateral aspect of the gastric jejunostomy, can you see that you created an ischemic bridge? And if you created an ischemic bridge of dead, non-viable tissue there and then fill it with titanium staples, could you imagine how that patient long-term would be a high risk for marginal ulcer?
Yes, sir. True, sir. Yes.
And then you would imagine, depending on the surgeon and how they create that gastrojejunostomy, you might see some surgeons with high marginal ulcer rates and high gastritis rates, and others with low gastritis rates. So here is where I'm going to come to something I went over quickly, but making a broad tip of the gastric pouch for the MGB allows you to move the staple line medial to give a collateral opportunity for the lateral neo-greater curvature staple line. Can you see those two staple lines begin to spread? Can you imagine that?
Yes, sir.
That is, in my opinion, critical in getting a long-term result where you see very low incidence of bioreflux gastritis and bioreflux marginal ulcer. And it's exactly opposite of what they do for Roux-en-Y, and so that's one of the problems. And so my suggestion is that patients who are smokers are candidates for MGB, but we need a surgeon who knows what he's doing. So when you do your first 100, don't do smokers for MGB. But after your first 100, when you're skilled and you know that you can perform the MGB little bioreflux and little marginal ulcer, then it's a good choice. The second thing is you ask about is what about GERD or bioreflux into the esophagus? May I comment on that?
Sure.
Yes, sir.
Okay, let's talk a little bit about this. We do hear that some surgeons, there's a very famous surgeon here in India who is over there in the eastern part of India, and I won't use his name, but he said he would start doing MGB, and I volunteered to come and teach with him and work with him, and he did not accept my offer, which is okay. He's a very famous surgeon, and he did a bunch of MGBs, and they all had bioreflux. He endoscoped them. Everyone has bioreflux, and so he goes to meetings. Often he is on the meeting before me or after me, and he says, MGB, they all have bioreflux. I have endoscoped them. They all have bioreflux. And I say, yeah, maybe yours do. I said, maybe you should not do MGB. But let's think about this for a minute. The MGB is an anti-reflux procedure. Can I explain?
Yes, sir. Sure.
Number one, of course, you lose weight. Yeah. Number two is the MGB is a low pressure system. I'm going to say that 3 more times. The MGB is a low pressure system. The MGB is a low pressure system. If we have a wide open gastrojejunostomy, even if there's any lower esophageal sphincter pressure at all, which way will bile tend to flow? It's going to flow along with acid and food out of that gastric pouch. You see? But now let's add one more topic. When we pull the bowel up from the lower abdomen and attach it to the stomach and then let loose, what happens? It pulls the stomach pouch down. It reduces the hiatal hernia. Can you imagine? Do you see what I'm saying?
Yes, sir. Yes, sir.
You see the small bowel hangs off of the stomach, grabbing the stomach and doing what it must do, which is what? To pull the lower esophageal sphincter complex back into the abdomen. Now, that's when it's done right. For example, I was talking to a surgeon from Canada recently, and he was anchoring the stomach body to the small bowel. He says, that's good, it won't twist. I said, no, that's not good, because what we want it to do is pull down and reduce the pouch. He's going, no, I don't want it to twist. I said, it doesn't twist. But see, the 3 components of the MGB make it a superb anti-reflux procedure. Now, on top of that, we'll say one more thing, which is, God forbid, the tragedy of tragedies occur, that the MGB patient in someone's hands develops bioreflux or gastritis. The first thing I would ask is, if you would, call me, because most of the time I can explain to the patient what's causing it and resolve it. But let's imagine for this discussion that you want to treat the patient surgically. Okay, let's treat the patient surgically in 15 minutes to treat bioreflux. Okay, in your mind, you can see an MGB in your mind. Okay,
yes, sir.
So let's go in and divide the afferent loop just near the gastrojejunostomy. You see that?
Yes, sir.
That takes 5 or 10 minutes, yeah?
Sir. Yes, sir.
Now do a side to side between the afferent loop, maybe 50 or 100 centimeters down, whatever your preference is, between the afferent loop stump and the efferent loop. That's what's known as a Roux-en-Y, yes?
Yeah, got it, sir. Yes, sir.
So that might take an unskilled surgeon maybe 20 minutes.
Okay. Okay. I think, Ankit, you got your answer.
Yes, sir. Yes, sir. Thank you so much, sir, for clarifying the question. Thank you so much.
My pleasure.
Okay. So I think, the take-home message that you gave, Ankit, you got it. Probably the smokers should be, in the initial learning curve, probably smokers should be sidelined till a surgeon has done minimum around 100 MGBs. Then should probably try attempting smokers as well. Yes, Prakash has joined now, probably. Prakash, do you have any questions to Dr. Rutledge or Dr. Santanu? You have any? Please come forward.
Good evening, Dr. Rutledge.
Yeah.
Sir.
Nice to
Yeah, you are audible. Go ahead.
see you after a long time. Sir, nice to always just hear your lecture, sir. I have been hearing your lectures in the last 12 years or more. And I have only 2 cases of this MGB done in AIMS Bhubaneswar. And they are only 1 year back I operated them, and they are doing extremely well. One patient, the youngest one, he was around 190 kilo, 21 years old. Now within a year, he has lost almost 100 kilo. He is now 80 kilo, and he is carrying on very well without any reflux, sir. Thanks to you, sir.
Okay.
Thank you, sir.
My honor, sir.
Santanu, you have any questions or any other faculty? Anybody else is there?
Maybe I should show some pictures of a twisted pouch. You might be interested in a few pictures of this.
Sure, no problem. Please.
All right, it'll take me a minute.
Yeah, no problem. You haven't shared your screen.
One moment. I'm bringing up, I just had to open a new set of slides, and I'm going to show it to you right.
Okay, no problem.
Almost. One more second. Almost there. Get ready and present. Window. All right, it'll take a moment. Tell me when you see the slides.
Yeah, it's coming up. Is
Good.
there?
Okay.
All right.
Okay, good. So this is the twisted pouch, and can you see this is the pouch tip? Can you see the cylinder here on the screen?
Mm-hmm.
Okay, so now imagine this is the lesser curvature here, and this red arrows, this is the vascularity. There is no more greater curvature.
Mm-hmm.
This is a staple line. There is no blood supply. The blood supply to this tip comes from here on the lesser curvature, correct?
Right.
Okay. Now, if we staple here, maybe some blood can come on the collateral aspect to provide blood supply here on the posterior wall. Can you imagine?
Right. Yeah.
But now let's staple here. If we staple here, now this is all dead tissue. There is no way between these two staple lines, in my mind, that this can have blood flow. Staple line here, dead tissue here. This becomes the inner wall of the gastrojejunostomy, right?
Mm-hmm.
That wall then becomes the site of marginal ulcers. Where do all marginal ulcers occur? Ask anyone, Roux-en-Y or MGB surgeon. It's the lateral aspect here. Greater curvature, the new neo-greater curvature with no blood supply, a stapled anastomosis here, and that is all dead tissue. It's all ischemic. So what we want to teach our surgeons, if you're doing an MGB, or I would even say for Roux-en-Y, is let this blood supply collateralize here. Let this have blood. So here again, vascular, lesser curvature. Neo, greater curvature, no blood supply anymore, no gastroepiploids. Good collateral blood supply if we move this staple line medially. Allow blood to come here and collateralize. We know the stomach is our friend. It's one of the best collateralized blood supplies in any organ in the human body. But if we are unwise and staple out here, staple line, this becomes a mass of dead tissue. Stricture is common then, stricture, ischemia, foreign body, ulcer, gastritis, and bile reflux. Bile can go into the stomach. It's no problem. Bile goes into our stomachs every day. It's if it's held up coming out. So stricture with bile, then you get bile reflux gastritis. Yes?
Okay. That means
okay,
that...
Sorry.
No, I mean, that it has to be centrally placed. The GJ, the gastrojejunostomy need to be absolutely centrally placed. That's the reason.
Even more, I would say, even more than at central is the minimum. At the best, it'd be medial.
Yeah, so that the vascularity will be much better.
Yeah.
Okay.
Now here is a look at what I would say is a good tip of gastric pouch. So first of all, lesser curvature is here, yes?
Okay.
And staple line is here. And now this is where the gastrojejunostomy is going to go. And we want that staple line here medially, yes?
Right.
But now watch, let me show you what many surgeons, particularly sleeve surgeons, do. Can you see the twist in the gastric pouch?
Mm-hmm.
Here is the lesser curvature. It's now pointing at the greater curvature.
Okay.
Can you see why this patient would have persistent nausea, vomiting, bile reflux, and obstruction symptoms? Because he brought the staple gun in from below and with the friction has pushed the lesser curvature almost 180 degrees lateral.
Okay.
You see it?
Mm-hmm.
Can you see it?
Yeah, sure.
So this lesser curvature, see how the vascularity is pulled over here. Totally, you can see how this person thinks they're doing a good MGB. This was posted from India by a surgeon saying, here is a good MGB. Is this a good MGB?
No, not at all. Not at all.
No. He used to be my friend.
Okay.
Now this one is a total twist. This is from a friend of mine from Germany. Do you see here? Here's afferent loop coming here. Here's efferent here. Is this a problem of MGB or a problem of the surgeon?
True.
Now, here, look at this. This is, look at this. You see the twist?
Yeah.
So what's happened is the staple gun, the surgeon is sitting between the legs. The staple gun comes in from below. He twists and kinks it. And now you see the twist. The correct angle is the green angle here. And because they think they know everything, they haven't asked, they just said, oh, I know MGB. It's nothing. It's nothing. That's nothing. And look what they've done. Now, when it's like this, where do you think you should put the gastrojejunostomy? It's suddenly, to this surgeon, it looks like should be anterior. No. Anterior is going to force almost a 180-degree twist. Think of that patient eating for the rest of their life into a twist of your stomach, 180 degrees. How do you think that would feel?
True. So the best one is to do an anterior gastrotomy, little maybe closer to the medial, that's fine, but should not be on the something like going near greater curvature. I think that's that should be absolutely fine.
So that's another example. I have more, but I thought you'd be interested in that one. You see how the error makes a difference?
Yeah, sure, definitely. Absolutely. So thank you very much, Dr. Rutledge, for spending the evening in India for us and morning for you. It's fine. So we really enjoyed your talk, the enthusiasm, the knowledge that you shared with everybody. We all are really happy. Our residents must have taken and got lot many info straight delivered to their gray matter. And everyone is surely enthused with your talk, your enthusiasm to teach and to share the knowledge. That's wonderful. We pray that you have a long life, long and healthy life to still go ahead and do much better work. So thank you very much, Dr. Rutledge. Thanks a lot. Thanks for joining and thanks for accepting my request. Thank you very much.
A great pleasure. Bye-bye.
Thank you. Bye-bye. Bye-bye. So thank you everybody for joining. Thanks.
Thank you, sir. Thank you, sir.
Thank you.